this is an 11-year-old kid with left-sided pelvic pain.
Okay. Can I scroll?
Yeah, of course, please.
Okay. Uh, okay. Yeah. 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 Okay. You said 11-year-old, right?
Right.
So this is a 11-year-old kid. I am being presented with a stir coronal image of the pelvis with both hips of a patient who presented with pain. So I can see that there are diffuse areas of stir hyperintense signal seen involving bilateral pelvic bones. Uh, this There is associated pelvic bones involving the iliac wings, femur, etc. These are associated with the mild adjacent hyperintense signal involving the muscles as well. The pubic bones are also involved. However, there is no other focal lesion seen. The facial spaces appear largely unremarkable. So, diffuse stir hyperintense signal seen involving the bones, multiple bones of the pelvis. So, with these findings, I would like the differential list is wide. I would like to see other images also. If possible, I can see T1 image.
Okay.
Uh,
So far, what are you thinking in terms of?
So I'm thinking in terms of a diffuse infiltrative kind of a process. It can be in this young age, it could be leukemia related infiltration. It could be some systemic infections or a metastatic disease from neuroblastoma, etc. But then for 11 years, neuroblastoma is slightly old. So yeah, in this, some kind of general systemic process is what I'm thinking in lines.
All right. So I'm going to share T1 weighted sequence. Just leave the control for a minute.
Yeah.
Yeah. Yeah.
Okay.
Right. You can scroll.
Yeah. I have to click it once. Yeah, I can scroll. Yeah. Okay, so the T1 weighted images reveal that there is a complete loss of fatty marrow that is supposed to be seen, involving practically all the bones. The even the bones of the spine are also showing absence of fatty marrow. So there is diffuse infiltrative process that is happening here. Apart from that, the visualized muscle appears slightly atrophic. Other than that, the joint spaces are, as I had seen on the stir imaging, also were well maintained. If possible, I would further evaluate this on a diffusion weighted sequence to further consolidate my findings, if available, and the post contrast images, if available.
Okay. So does the T1 narrow down your differentials?
Yes, it does narrow down my reflections.
Okay. Now, what are you thinking in terms of?
So now I'm thinking in terms of diffuse infiltrative marrow-related pathologies like myelofibrosis and in those lines basically.
Okay. All right.
Yeah,
This is a diffusion weighted sequence.
yeah. Okay, on the diffusion weighted imaging, I can see high signal involving the visualized signal abnormalities in the previous sequences. Apart from that, there is no extra osseous abnormal diffusion signal seen. In my routine practice, to confirm the two restricted diffusion, I would like to confirm it with the ADC maps also.
Okay.
If
Do you see high diffusion signal in all the bones or just
no, no,
specific
only,
areas?
only few of the bones actually. Yeah. So only in the iliac bones, specifically on the left side and on the right side also. So basically, it's not a very focal lesion. It's a diffuse process with patchy areas of diffusion restriction. If it were showing ADC drop.
So the areas which are high on DWI, like this left-sided iliac bone, these are only
Yes.
restricting. Rest of the things are not restricting.
Correct.
Yeah.
Yes.
So now what are you thinking in terms of?
So I'm thinking in terms of active on chronic kind of a process. So I'm thinking in again my differential list is the same. The differentials would include features of myelofibrosis versus versus conditions in which there is abnormal hematopoiesis. Again, and other third differential diagnosis would include infiltrative processes like blood dyscrasias like leukemia, uh, ALL, etc.
Okay.
So,
So
yeah,
this is your post-contrast T1 fat
okay,
suppress.
okay. Okay. Okay, so post-contrast fat suppress sequence reveals focal areas of non-enhancement. So there are diffuse enhancement that is seen in the marrow. However, the areas which were restricted diffusion reveal non-enhancement. So I feel that I'm looking at some sort of bone infarcts which are there involving the bone with the excessive rest of the marrow revealing excessive marrow red blood cell production. So myeloproliferative kind of a condition. I would also so my one of the differential diagnosis would include a sickle cell disease as well. I would convey these findings to the referring physician. I would like to review the previous imaging if available, especially the ultrasound of the abdomen if possible, or if in this MRI, if I have a upper abdominal cuts, I would like to evaluate if the what is the status of the spleen. There would be
Spleen was
other
normal.
spleen was normal. Okay, so then if spleen is normal, then I should think of something else now. So if spleen is normal, yeah.
Okay, so what are your top three differentials and what would you like to do next with the patient?
So next, I would like to evaluate with the peripheral smear, etc., of the patient if there are blast cells or leukemia-related picture that is seen. One is that. Second, I would like to review the previous radiographs, X-rays, etc., for of the patient if possible, and take this thing further from there.
Where further to where?
Further I'll refer this patient to the hematology department, the hematology MDT. I'll discuss this case with the hematology MDT with all the relevant blood reports
All right.
and the previous history also of the patient.
All right. Thank you, Candidate E. Candidate E, very, very well presented. You picked up all the findings in the first look, and the examiners prefer if you form a list of differentials on the first sequence as well, which you very well did. So you said that there is diffuse infiltration of the marrow, predominantly involving the pelvic bones and femora, and this is likely a diffuse infiltrative disease. Okay. So one more thing, you also mentioned that there is some hyperintensity in the left-sided muscles as well, including the iliopsoas muscle, left-sided glutei, and there was one more finding here. There is diffuse bulkiness and hyperintensity in the left piriformis muscle. There is a fluid-sensitive, the fluid intensity collection, which is also showing some hypointense areas within, and yeah. So also you will notice that there is some asymmetric hyperintensity on the left side as compared to the right side of the iliac bone. When we look at the T1 image, you very well picked this up that there is diffuse hypointensity of the marrow and there is fatty replacement. So always mention that this hypointensity is less than that of adjoining muscles or the intervertebral disc. So this is a diffuse marrow infiltration disorder. The list of differentials is long. So this could be either leukemia or myelofibrosis, systemic mastocytosis, or lymphoma. Then you can have metastasis or myeloma. You move on to other sequences of MRI to further narrow down your differentials. So on the diffusion weighted image, there is some preferential hyperintense areas here on the diffusion weighted in the iliac bone. Now, these similar areas are show no enhancement on the post contrast T1 images. So you said that this represents areas of bone infarct, but bone infarcts do not show diffusion restriction. And if it is not enhancing, anything that is not enhancing or peripherally enhancing, which is showing diffusion restriction, always think of a loculated fluid or an abscess. So as you can also see on the post contrast images, there is preferential enhancement on the left sided pelvic bone and the femora, and there is more enhancement along this non-enhancing area here, and there is enhancement of the left sided iliopsoas and gluteal muscles as well. So this actually is a case of diffuse marrow involvement with secondary infection. So this diffuse marrow enhancement is actually osteomyelitis, and the non-enhancing or the subtly peripherally enhancing areas are intraosseous abscesses. So this came out to be a case of leukemia in an B cell ALL in an 11-year-old child, and these were fungal abscesses in this kid. And this was also a collection within the left piriformis muscle. This was showing dark signal on T2 or stir, which showed blood products as well, because the patient had thrombocytopenia. Patient also had febrile neutropenia. So this is a typical FRCR type of a case where there'll be one major finding, and then there'll be small findings which are very, very clinically relevant. So you mentioned that the patient has to go to the hematology MDT. That was right. What you mentioned that you would like to rule out a sickle cell disease. So if you have one particular sequence or a scout image, you rule the particular diseases in your differential in that particular image. So you could have said that there is no H-shaped vertebra or there is no AVN. So you could have ruled that out. So in clinically in the MDT, you also should have gone for a bone marrow, and this also needed to be assessed on a bone marrow aspirate or a biopsy. This came out to be pus, and this was actually a fungal infection. So yeah, very well done. Even though you missed the osteomyelitis, I'm still going to give you excellent in observation. You because you picked up all the findings and you very well articulated your answer. So that was very well done. Good job.
Is my screen visible?
Yes, ma'am. I can see.
Okay, so I'll just give you. Can you ask for remote control,
Sure.
or I'll
Yeah,
just give it?
I'll ask it.
Yeah, yeah. So please try scrolling, and you can start. This is an adult patient who presented with complaints of abdominal pain.
Yes. So I've been presented with axial non-quota CT, lower chest and abdomen of an adult patient who has been presented with abdominal pain. I will just take a moment to look at the whole stack of images first before describing my findings. I'm scrolling from cranial to caudal. The patient has abdominal pain. I could not say any gross abnormality as of now. He's a male patient, and there is a bit of fluid in the TV sac. I'll just go back to the. So okay. The bowel loops appear largely unremarkable. I'll go systematically. The liver appears normal. The gallbladder appears normal. I'm looking at the pancreas. The pancreas is normal. The kidneys. There are some. No, there are some non-obstructing. I think they are vascular calcifications.
Okay, you can ignore that. They might be early Randall plaque or vascular
Okay.
calcification. You can let them go.
So I'm looking at the uh, the spleen appears normal, and the bowel loops appear largely unremarkable. There are some calcific densities involving the uh, some small bowel loops, ileal loops. So I could not find any. Like I would just look at the vessels once. I could not find any gross abnormality in this scan. So I would like to take a look at the post contrast images if available.
You just hold on a second. I'll give you the post contrast images. Just leave the control. So, okay, you can scroll.
So these are the portal venous phase images. As I can see, the liver is normal. There is no intrahepatic biliary duct dilatation or any focal liver lesions noted. Uh, the main pancreatic duct appear
It's fine. You can ignore the pancreatic duct.
okay. Mm, I'm looking for the appendix.
Appendix is fine. You can ignore that.
Okay. So the urinary bladder appears like it is partially distended. I would like to look at it in the
The UBU is fine.
Okay.
The patient, okay, so I'll just try to help you here. The patient mainly had upper abdominal pain. So just try to focus on the upper abdomen. And he had complaints of some episodes of gastroesophageal reflux. Does that help? Just try to look for the anomaly now.
Okay. I'm looking at the esophagus and the stomach. The gastric folds are appearing very prominent.
Yes.
So I'm just I'm looking for the surrounding evidence of fat stranding. Mm, there is no significant fat stranding as around the stomach. I'm looking at the duodenum.
Okay, so you said that the gastric folds are prominent. What are you thinking along the lines of?
If it is like epigastric pain, then it could be due to gastritis.
Okay.
And gastroesophageal reflux. I could not see any abnormal thickening, like focal or diffuse thickening involving the stomach. So the carcinoma is ruled out. Another thing can be um, the menetrious disease, but there are no any symptoms of edema or like protein loss. So it is ruled out. Another thing can be it could be varices. I can see there are prominent vasa recta, like prominent vessels around it. So
Okay, maybe the radiologist on duty found something abnormal on the non-contrast scan. So he got an early arterial phase also acquired. So just let me give you that. Maybe that helps you find out the pathology. Try to scroll and look if you can find anything abnormal here.
yes, ma'am. Okay, so I have been given the arterial phase images. I'll just so the stomach wall is hyper enhancing on the arterial phase images.
Yes.
So this could
Apart
be
from the stomach wall, can you find anything else abnormal in the upper abdomen?
okay. The duodenum, the wall of the duodenum is also a bit thickened. So I'm thinking in terms of peptic ulcer disease with gastric and duodenal wall thickening.
Okay.
So I'll inform these findings. Apart from it, I would like to, in my routine practice, I would like to look at the any if there is any evidence of perforation of the ulcer, but there is no surrounding like free fluid or free gas. I would like to look at the lung window images as well for to look at the free air in the peritoneum.
Okay.
So as of now, it seems like peptic ulcer disease. So I would like to uh, inform these findings to the referring physician. Will refer this patient to upper GI MDT for discussion and would advise upper GI endoscopy for confirmation of the findings. And this patient would benefit from. I would also advise H. pylori testing,
Okay.
and this patient would benefit from like anti uh, uh, like
Okay, if I tell you that the patient has had multiple episodes of, gastritis, gastroesophageal reflux,
so I
and
would
you,
also like to look at the images in the coronal scan to look if there's any evidence of like uh, hiatus hernia.
okay, so, so I was saying that if the patient is having recurrent ulcers, recurrent, gastroesophageal reflux, very aggressive, not being managed by, the PPIs and everything, would you be suspecting anything else abnormal in the upper abdomen? Can you find
Uh,
anything else abnormal near the duodenal wall?
okay. Mm. So the duodenum, I'm looking at the duodenum. The third part of duodenum is crossing the midline. Also, I'm looking for any obstructing lesion or any fistula.
Okay, no problem. So I think you.
There is this hyper-enhancing lesion
Yes,
in
yes.
the duodenal wall. I think it is enhancing in the arterial phase. So I think it may be an aneurysm from the like gastroduodenal artery, or I would like to look at it in the other phase, but it does not show any like direct. I would like to look at it in the other phase, like different portal venous and delayed venous phase also.
Okay.
Um,
So you want me to give you portovenous phase again?
yes, ma'am, if possible.
Just a minute. Here's the portovenous phase.
Okay, so I've been given the portovenous phase. As I'm saying, uh, the lesion, the observation show enhancement the same as the portal vein. Mm, so it confirms my finding of aneurysm.
Okay.
So
Okay.
I'd like
So please summarize your case.
so in conclusion, this is like peptic ulcer the stomach wall thickening with duodenal wall thickening, and in keeping with peptic ulcer disease with possibly like complicated by the gastroduodenal artery aneurysm formation.
Okay. A 45-year-old male who presented with abdominal pain. So I think you got a bit stuck here with the findings. I tried to prompt you towards the finding, and then you were able to pick up some of the findings that there is gastric rugal fold thickening. You were correct to point out that it is hyper enhancing and that you are thinking along the terms of Menetrius disease, right? You also pointed out that since it is involving the first part of duodenum, you will also be thinking in terms of peptic ulcer disease. And you were good on the part that if you're suspecting peptic ulcer disease, you would be looking at the lung windows to look for any evidence of pneumoperitoneum, right? But the main pathology over here, which ideally one should have at least like have a like you cannot characterize, but can you see this large lobulated lesion over here adjacent to the duodenum?
Yes.
I'll just show you an arterial phase that how well and how enhancing it is. Can you see this lobulated lesion over here?
Yes.
So I think you missed this, and this is a lobulated lesion over here. You were correct to point out another hyper-enhancing lesion adjacent to the duodenum. This you pointed out very well. But again, you mentioned that you are suspecting it to be an aneurysm. So, aneurysm will be always, you'll be able to make out that it will be enhancing as well as the vessel. Can you appreciate the contrast here in the aorta? It is not that well enhancing. It is not opaque. It is showing soft tissue attenuation, which is hyper enhancing, which is typical of neuroendocrine tumors.
Yes.
Now, when I tell you neuroendocrine tumors over here, another over here, then you look at the duodenal wall, you pointed out there is thickening, but do you appreciate another enhancing lesion here in the wall of the duodenum?
Yes, sir. Pessaro's triangle.
Yes, so these are multiple gastrinomas with a typical location in the Pessaro's triangle. Can you tell me the boundaries of Pessaro's triangle?
The head of the pancreas, then the cystic rectum CBD junction, and the second and third part of duodenum junction.
Yeah, so the 3 points for the Pessaro's triangle are the cystic duct and the CBD. Second is the second and third part of the duodenum. And the third point is that between the junction between the neck and body of pancreas. So, whenever an examiner is giving you history, he or she is trying to prompt you. They don't try to mislead you. So, whatever you are saying, always take a pause and very carefully try to take hints with the history. So, gastrinomas typically present with, uncontrollable gastritis, peptic ulcers, and gastroesophageal reflux. Additionally, apart from that, there are associated rugal fold thickening as in Menetrius disease, but this can be associated with chronic gastritis, right? So I would just like to, advise you that whenever you're not able to find anything abnormal on the first look, don't take much time. Just maximum 30 seconds, take a quick scroll, and then and there you can just say that all the visceral organs are appearing grossly normal. And on first look, I do not appreciate anything abnormal. And then you start carefully looking at the review areas. Like in abdomen, your review areas mainly are the bowel and the edges of the film, right? So you should be quick to move to that because the approximate time you took for this was around 10 minutes. And, I tried to prompt you. Even then, I think you were not able to pick up, but that's fine. So, there will be cases where you're not. So just try to correlate with the history. So actually, if you would have picked up gastrinomas, I would have asked you about, something syndromic which you will be looking for in such patients. So can you tell me which syndrome you will be looking for in patients with gastrinomas? Zollinger-Ellison is the clinical syndrome. Any other
or men, okay.
Yes, so you will be typically looking for men syndrome. Men 1 and men 1 is typically associated with parathyroid pathologies, pituitary pathologies, pancreatic tumors. Most common tumor in such cases is insulinomas followed by gastrinomas, right?
Yes.
So you were good to mention the part of the MDT. You could have mentioned previous imaging. You mentioned upper GI. But once you could have picked up the finding, then your Viva would have been on men 1 and that you will look for other associated. You would have got an MRI, SELA done to look for any microadenoma, serum prolactin levels, growth hormone levels. And additionally, you could have, screened the individuals and all that stuff.
Okay.